Welcome to our roundtable. I'm Jamile Shammo, a hematologist from Northwestern University. And today we're going to be talking about treatment options, specifically focusing on patients with low-risk MDS in first-line setting. Today I am joined by a panel of experts, and I would like them to introduce themselves.
Hello, I am Melhem Solh from the bone marrow transplant at Northside Hospital, Atlanta, Georgia.
Hi, I'm Somedeb Ball from Vanderbilt University Medical Center in Nashville, Tennessee.
Hello, my name is Bart Scott. I'm from the Fred Hutchinson Cancer Center in Seattle, Washington.
Hi, I'm Palmisiano from Rutgers Cancer Institute.
And hello, I'm David Swoboda from Tampa General Cancer Institute.
And our goal today is to talk about how do they decide on what to choose in terms of treatment for patients who have MDS. What is their timing for initiation of therapy, and what is the sequence that they would utilize in this setting? Today, we're going to be discussing treatment options for low-risk MDS in particular, focusing on timing for initiation of therapy and choice of therapy as governed by certain parameters, perhaps transfusion need or other biological markers, etc. Let's talk about the treatment landscape in MDS in general. Do you see that there is any change in trends when it comes to treatment of patients who have low-risk MDS in first-line setting?
Yeah, it's a very interesting time to be an MDS doctor, I think, because we really have 4 or 5 upfront options to pick from for our patients, including things like ESAs, imetelstat, luspatercept, HMAs themselves, and nothing. We have increasing data that can help us pick between these 5 agents.
And when you are thinking about erythroid therapy, for example, do you find that there's any change in trends recently?
So, I think in academic settings, because of the COMMANDS data, the phase 3 clinical trial of luspatercept versus ESA in non-del(5q) patients that have an EPO level less than 500, more and more providers are moving to luspatercept in the front line. I think especially in academic settings. In the communities, there still is a high uptick of ESA use. And so I think over time, and the trend is moving in the direction towards more academics using more luspatercept because of the better data, not just in transfusion independence rate at 12 weeks and increased hemoglobin over 1.5, which is the primary endpoint of the COMMAND study, but also the duration of transfusion independence. So we see that it's about almost a year better in a patient that's treated with luspatercept versus an ESA. And so ultimately, because of that data, many academic physicians have adopted luspatercept for a lot of their patients in the frontline setting. But I think the big trend is really getting that broadly out in the community, having more community providers moving away from ESAs and more with the therapy that we think is better in a lot of low-risk MDS.
And I think something that's going to help with that a lot is long-term outcomes that we're seeing. Some publications come out showing, improved survival with giving luspatercept up front with the long-term follow-up, the COMMANDS data. And I think that's going to help, get the word out to the community setting because there's nothing like survival data to increase the uptake of new medications.
And I think in the community, there is a misconception still happening, which is slowing down that transition because early on in the second line, it was only for RS-positive patients. And a lot of community physicians still have that impression about, well, they're not ring sideroblasts positive, so I'll start with ESA first, whereas the COMMANDS data was actually independent of ring sideroblasts, and you got to see the benefit on both subgroups.
Well, I'd like to thank the panel for a provocative discussion on the management of low-risk MDS. Thank you all for participating.
Thank you.
And thank you for joining us.
Thank you.
Thank you.
Thank you.